Welcome to One Stop Nursing. Today we will discuss about beta-2 adrenergic agonist. Please like, share, and subscribe. Okay, now let's look at the mechanism of action, types of beta-2 agonist, and what are the uses of the drug. Now let's look at what the beta-2 adrenergic receptors are and what the sympathetic agonist mean. Okay, so first before we go on to this, we need to know what the receptors mean. The receptors are the substances that's actually present on the surface of the of any kind of cell. So when they bind to a specific substance, they produce an effect. For example, let's look at the beta-2 receptors. Now, let me get a pointer here. So these beta-2 receptors are present on the smooth muscles in the lungs, right? So what do they do? So these beta-2 receptors are stimulated. Remember I said receptors are any kind of molecules that get triggered by another substance. So what is the substances that triggers these beta-2 receptors? Epinephrine and norepinephrine are the two substances that stimulates these beta-2 receptors that's present in the smooth muscles of the lungs, correct? Okay, when they get stimulated with the epinephrine and the norepinephrine, what do? They produce the smooth muscle relaxation and bronchodilation. Okay, so is that desirable? Yes, for an asthmatic patient, their bronchus and the bronchioles are very narrow. That means they are almost closed up, so they can't breathe. The air cannot go in and go out. So we need more of this activity of these receptors so we can produce the effect of the smooth muscle relaxation and thereby bronchodilation. Makes sense, right? So any drug that causes the same effect of the receptor, so the drug actually mimic or resemble the epinephrine and the norepinephrine, so the receptors, the beta-2 receptors on the lungs think that, oh, it is the epinephrine and the norepinephrine. So the drug goes and sits inside those receptors and they produce the same effect of the receptor itself, so which is the bronchodilation. And that's why they are called agonist. Agonist meaning any drug that produces the same effect of the receptor when it gets stimulated is the agonist. Okay, so hence the name beta-2 adrenergic, meaning they are stimulated by the epinephrine and the norepinephrine, which is the part of the sympathetic nervous system. And an agonist meaning they create the same effect when they get stimulated. All right, so if you're curious about what the sympathetic nervous system mean, and then where this norepinephrine is getting, why this norepinephrine is getting secreted, now we can look at, okay, so there's two things that you need to understand. So already you know what a receptor is, that's present on the effector, that's present on any cell in the body, to be simple. And then you have to know what a ganglia mean. A ganglion or a ganglia mean it's a collection of the nerve cell bodies. So it's all kind of a meeting place, like in a room or in a highway, where all the roads meet together. So that's the ganglia. So there are two things that we need to know. A preganglionic neuron, meaning that is before the ganglion, and a postganglionic neuron, meaning after the ganglion, correct? So the preganglionic neuron in a sympathetic nervous system secretes acetylcholine. So that's a neurotransmitter, meaning, like humans, we talk different languages. The neurons talk different languages as well. So when they talk to each other, they produce a a substance called a neurotransmitter. So that's the acetylcholine in this case, correct? So the preganglionic neuron, when they get stimulated, so where are these preganglionic neuron arises onset, or they arises from in a sympathetic nervous system. So they arise from the thoracic spinal nerves. So the spinal nerves that's at the in the vertebra on either side of the vertebral column, the nerves come out of it, right? So those fibers are the preganglionic fibers for the sympathetic nervous system. And when they end in the ganglia, so these are the thoracic ganglion that they end in. What do they produce? They produce acetylcholine. Okay, they produce acetylcholine, so what? So, and then there is the postganglionic neuron. There is another neuron that transmits the impulses or carries the impulses after the ganglia, which is called the postganglionic neuron. And what kind of receptors do they have? Remember the receptors? Okay, anything on the surface of the cell, right? So these receptors, the name is the nicotinic receptor, and they respond to acetylcholine as well. So these nicotinic receptors carries the impulses along the axon, but they talk a different language. What is the language? Norepinephrine. So that's the language that they produce, and this norepinephrine, when they get onto the beta 2 receptors on the lungs, they produce smooth muscle relaxation and bronchodilation. Makes sense? I hope you got it. Otherwise, you can rewind it and then listen to it again. All right, what is a rescue inhaler? So before we go into that, we need to know what is SABA mean. SABA means it's short-acting beta-2 adrenergic agonist. What does S mean? S is the short-acting, B means the beta-2 adrenergic, and A is the agonist, of course. There is another drug called SAMA, which we can look at it when we talk about the anticholinergic drugs. So the way for you to remember, to not to get confused about the SABA or the SAMA for rescue inhaler, you can always think that B comes before M, right? So you do the SABA first before you give the SAMA drug. All right. So the prototype drug for SABA, which is the short-acting, is the albuterol. So albuterol inhaler is given for a patient who is having a acute asthma attack or being very symptomatic of saying that the patient has tightness of chest, unable to breathe, coughing, and things like that. So when do they start acting? So as soon as the patient takes the inhaler, within 5 minutes, it starts acting on the lungs, producing the bronchodilation, right? So how long does it stay in the system, or how long does it act? It acts about like 3 to 5 hours. All right, so as the name suggests, it's a rescue inhaler, and it can be repeated 3 times. Say, for example, somebody's having a asthma attack, and so they take a puff, wait for 20 minutes, take another puff, wait for 20 minutes, and take another puff. So in between those puffs, you need to educate the client that they need to be knowing whether they're getting any better. So if they're not getting any better, so they should not wait for the 3 times, and they should call 911 or get to seek medical help. So, but if they're getting better, they can do up to 3 times at 20-minute intervals. Okay, all right. Okay, so this is the pharmacology presentation. So we're not going to go in depth about management of asthma, but I want you to know that this albuterol, or the short-acting beta-2 agonist, or the long-acting beta-2 agonist, can be used for the long-term control of asthma. So what does that mean? When patients have asthma, initially they will be getting only the SABA, which is the short acting. Remember that? Yeah. And then if their symptoms are not controlled, they get something called the inhaled corticosteroids. That's what ICS mean. And they also get PRN SABA as needed when patients are symptomatic. And then they get the same daily and PRN combination. So it's a combination drug of the inhaled corticosteroids and also the formoterol. Formoterol is a long-acting beta-2 agonist. So long-acting, would you give this for a rescue inhaler? No, you would give only the SABA, right? And then the step 4, okay, the patient's symptoms are not controlled, then we're going to add something else. So we're going to do daily and PRN combination of medium dose. Here, this is the low dose steroid, and here is the medium dose steroid. And now you see it will be the high dose steroids, high dose steroid with the LABA and a LAMA. LAMA, we'll talk about that later, and the PRN SABA. So SABA as usual. And then if the symptoms are still not controlled, they're going to go to high dose steroids, LABA, and an oral systemic corticosteroid. So this inhaled corticosteroid, in addition to that, they're going to give oral corticosteroid because that's a little bit more effective because it's systemically absorbed, right? So I'm just giving you an overview of what's the use of the SABA and the LABA, SABA and the LABA, okay? So SABA, or the beta-2 adrenergic agonist, can also be given during the exercise-induced asthma. So what does that mean? When a child goes to run around, all of a sudden they get this asthmatic attack where they can't breathe, they struggle to breathe. So this happens so fast within 5 to 10 minutes. And what happens, when the child gets this attack? They usually get relieved 20 to 30 minutes, but this is only a mild attack. So if they get very severe attack, it can be life-threatening. So the patients are treated prophylactically, meaning before anything happens, right? For example, when the patient goes for a dental procedure, and if they are diabetic and prone for infection, they are given antibiotics before the patient goes for dental extraction. So that is prophylaxis. Same thing like before surgery, patient gets a dose of antibiotics. Why? Because they don't have infection yet, but they want to prevent the infection that may be happening after the surgery, right? Same thing, before the exercise induced asthma can happen, patients are given the SABA. When are they given? Like 5 minutes before the exercise, right? So cromolyn, there's another drug, is a segue between, from this drug, but you need to know all that within the context of the exercise-induced asthma. So these are, most often asked questions. So cromolyn is also another drug which is called a mast cell stabilizer, which is given 15 minutes before the exercise. And there's another drug called leukotriene modifier. It's a tablet form, so it is given 2 hours before exercise. Exams or the NCLEX likes to ask questions about the timing of administering these drugs. So make sure you remember them. Okay, now let's look at what is a long-acting beta-2 adrenergic agonist mean. So remember, there are 2 types of beta-2 adrenergic agonists. So one is the SABA, the other one is the LABA. SABA is short-acting, LABA is long-acting. So long-acting meaning it takes about 30 to 40 minutes to start acting, and then the duration of the action is about 12 hours, stays longer in the system. So the prototype drug is the salmeterol for the long-acting beta-2 agonist. And so what did they use for? They are also used for the long-term management of asthma. Remember, we looked at the chart that talks about the different treatments with different symptomatic treatment for asthma. So this is considered for the long-term control of asthma. Remember, this is never used as a solo therapy, meaning this is not the only drug that's going to be used in the treatment. Okay, so you got to know what the difference, what does that mean? So meaning sometimes SABA is the only one used during treatment when the patient have mild symptoms. So the LABA will never be used only by itself. So it can either be used with the steroid and also the SABA and with other inflammatory mediator drugs, okay, modifier drugs. All right, so remember that never used as a solo therapy, or it can never be used as a rescue inhaler. So what does a rescue inhaler mean? So that means the patient is having a asthma attack right now, and so the medication should start acting within 5 minutes, right? So, but remember, this takes about 30 to 60 minutes. So, is it going to be working? No. How long can you stop? How long can you be able to stop breathing? Not very long. Even if I, pinch my nose, start pinching your nose and see how long you can stop breathing. Probably a minute or so, or if they're very athletic, probably 2 minutes. So if it takes 30 to 60 minutes to act, would you give this as a rescue inhaler? No. Okay, now let's look at the adverse effects of the beta-2 adrenergic agonist. And remember, beta-2 adrenergic receptors are present on the lungs. And what do? They activate the beta-2 receptors and produce bronchodilation. And there are also other beta receptors, and those are the beta-1 receptor, and it is present in the heart. And what do? They stimulate the heart to increase the rate, force of contraction, and the blood pressure. So when you give a drug which is a beta-2 adrenergic agonist, it not only stimulates the beta-2 receptors, but it also stimulates very little the beta-1 receptors on the heart as well, and which causes the palpitations and the chest pain. So you have to be careful when you give this drug to a patient who has cardiac disease. Okay, now let's look at the adverse effects of the central nervous system. So this drug actually crosses the blood-brain barrier and it gets into the brain, and it causes tremors, nervousness, restlessness, headache, and insomnia. So it is a part of the sympathetic nervous system, right? So it can be more like a stimulant. Have you heard of the fight or the flight response? So it actually stimulates more of all the stimulatory activities or the functions of the organ itself, so thereby causing nervousness and restlessness. So if it gets to a point that the patient can't tolerate it, so they have to report it to the healthcare provider. Now we have gotten to the meat of the lecture itself. So what's the nursing intervention? As nurses, we are supposed to assess the patient before we give any drug and after we give the drug. Why do we need to do that? Before you give the drug, to have a baseline understanding of how the patient is doing, and also when you give a drug, so if the drug is working or not, and so you need to assess their system after you give any drug. So when we talk about the respiratory system, what are we supposed to assess for? You assess the rate, the pattern, the breath sounds, and also the use of the accessory muscles, pulse ox, and also the coughing if they have any other symptoms, coughing, mucus production, things like that. Okay, so, and you also have to educate the patient on the administration of the drug. So there is metered dose inhaler, which is the MDI, and this MDI is a type of inhaler, right? So you have to educate the patient about the correct way of using the inhaler. So they have to shake the inhaler, breathe out, not into the inhaler, breathe out completely before they seal the mouth and take deep breath. And also pressing the canister at the same time. So there are a lot of YouTube videos that you can go and watch. I just had it there because you have to educate the patient on the administration itself. And so there are a lot of questions about this, so make sure you know more about the MDI. And also the DPI. DPI is the dry powder inhaler, so this doesn't have the propellant, where the MDI has the propellant. And DPI do not need a hand coordination, so this is given for more elderly patients. It is comfortable for elderly patients, and if they do need an MDI, they can use a spacer, okay? And yeah, so the other thing is you need to know what you have to educate the patient about the acute attack. What can they do? So you can use the SABA 3 times in a 20-minute interval. And you also have to watch for and also educate the patient on what are the other signs and the adverse effects of the heart and the nerve. You have to actually watch the patient, because sometimes the patient cannot tolerate an activity because of the shortness of breath. So you would have to monitor the patient and see if they need the inhaler or not. And then if they do need it, you have to document it, and of course you have to let the healthcare provider know about that. And also the sleep, monitor the sleep of the patient, and also the nighttime cough. These asthma patients, they do have the nighttime cough. Based on that, the treatment will be changed or modified, okay? And also the insomnia. Remember the CNS adverse effect, and that's why patients have the insomnia. So the other thing is you have to watch the patient do the inhaler or administer themselves the medication, so you know that they are using the proper technique, right? And also especially in the teens, right? So the teens are very cautious about conscious about their body image, so they don't want to take the inhaler in front of their peers and their friends, and they don't know it. So you, as a nurse, you would have to be cognizant of these body image disturbances that the patient can have. And so when you see it, you would have to educate the patient the importance of taking the drug and what can they do in terms of making them very comfortable around their peers. All right, you have to educate the client. So what are you going to let them know, especially about the administration? Remember, administration is the key. If they do not administer the drug properly, the drug cannot take effect, right? So remember that I talked about the MDI and the DPI. So you need to let them know about the proper administration technique and watch them do it. And also you have to let them know about the time. Timing of the drug is very important. How long they can take it, how often they can take it. So you would have to educate them and make sure they understand that. And also how many times they can take it. They cannot be taking it as they like. So they have to follow the prescribed routine or the schedule. And also they should keep a log, because sometimes different patients get triggered by different things. So they have to keep a log of what the triggers are, which caused their asthmatic attack, and also document how often they have taken the rescue inhaler during those triggers. So that can help the healthcare provider to modify their treatment plan. Okay, let's look at what adverse effects that the patient need to watch for. So they will have to watch for the chest pain, palpitation, nervousness, and tremors, and headache and insomnia, right? So it will be normally present because this is the adverse effects of the drug itself. But when it gets to a point that they can't tolerate it or it interferes with their life, then they have to notify the healthcare provider, right? I mean, this drug can cause palpitation and chest pain and nervousness and tremors. So, you have heard of, did you drink so much coffee because your hand is shaking? Because it can cause tremors, because coffee is a stimulant. So you have to avoid caffeine when you're taking this drug, okay? So that way you don't cause these usual side effects, which is the chest pain, palpitation, and the tremors, become too much when you add another stimulant while you're taking this beta-2 adrenergic agonist. So you have to educate the client that they have to avoid caffeine and other stimulants. Of course, you don't want to administer beta-2 agonist drug if they are already allergic to the drug itself or the similar drugs in that prototype, okay? Okay, beta-2 receptors are not only present in the lungs, they are also present in the liver. So because they are present in the liver, we need to know what happens when they get stimulated in the liver. Remember, beta-2 receptors, when they are in the lungs, they produce bronchodilation. When they are in the liver, what do? They break down the glycogen, which is the storage of glucose, to the glucose. So that means it increases the blood sugar level. So you got to be very careful when you give this drug to a diabetic patient, right? I mean, it's not going to cause like a whole lot of increase in blood sugar, such as the oral steroid or prednisone, oral prednisone. So but you still need to monitor the blood sugar level in patients with diabetes when you give this beta-2 adrenergic agonist. All right, so we already saw what's the beta-1 receptor is. So it is present in the heart, and when they get stimulated, they produce what? They produce increase in heart rate, increase in force of contraction, and increase in blood pressure. All right, so beta-2 adrenergic agonist drugs such as the SAMA and the LABA, albuterol and the salmeterol, when we give it to the patients, they not only activate the beta-2 receptors on the lungs, but they unintentionally, so that's not the intention, but it also can stimulate the beta-1 receptors in the heart. So what's the problem? So if the patient is healthy, there's not usually much problem, but the patient, when they have a heart disease such as a hypertension and a heart failure, remember, so they increase the heart rate, force of contraction, and blood pressure. So beta-2 adrenergic agonists can increase these, and if they increase the blood pressure in already a patient who has hypertension, then that's a problem, right? So you would have to monitor their vital signs while you're administering this drug, and if it gets out of control, you would have to let the healthcare provider know. Okay, first we talked about what's the beta-1 receptor, right? So what is the beta-1 receptor? So that's in the heart, and when they get stimulated by the epinephrine and the norepinephrine, they increase the heart rate, force of contraction, and the blood pressure. When patients have heart disease such as the congestive heart failure, their heart is working really hard. So in order to reduce the workload of the heart, they give some drugs called the beta blockers. What do they mean? What do they mean? So remember, beta blocker meaning it is blocking the action of the beta receptors on the heart. So what do? They reduce the workload. So that means they're going to decrease the heart rate, decrease the force of contraction, decrease the blood pressure, right? So that is desirable for a patient who has a congestive heart failure. But remember, if a patient is taking a beta blocker, but it is also asthmatic, meaning they also need the beta-2 agonist inhaler. So when we give the inhaler, both have an opposing effect, right? So this is a beta blocker, and that's an agonist drug, right? So we have an agonist drug. So it's an agonist and an antagonist. So they actually kind of cancel out each other. So it is also affects their treatment of the heart failure, and it also affects the treatment of the asthma. So when patients taking both beta blockers and beta-2 agonist, they have to be monitored because their symptoms of asthma may not be well controlled. Same thing when patients take this beta-2 agonist inhaler, their heart failure symptoms may not be controlled because that can increase the heart rate and the force of contraction and blood pressure, right? So both can have opposing effect and can cause problems in their treatment, all right? So you would have to be careful when patients are taking beta blockers in an asthmatic patient. Okay, now let's see what's the monoamine oxidase inhibitors do. So monoamine oxidase inhibitors, meaning it is inhibiting something. So what is it inhibiting? Normally monoamine oxidase, they break down neurotransmitters, so which are, norepinephrine and dopamine. When they break down, what happens? It decreases the levels of the norepinephrine and the dopamine. Remember, dopamine is a good one, right? So when they inhibit the monoamine oxidase, meaning it cannot break down, so it increases the norepinephrine level. So that makes sense. Okay, let's think about that. Okay, so monoamine oxidase is the one that breaks down the norepinephrine. So we're thinking that's a bad thing, right, in a patient who has depression, because they need more of the dopamine. So what we are going to do, we're going to give a drug which inhibits this activity. All right. Okay, so that means it inhibits the breakdown of the norepinephrine. So meaning more of norepinephrine and dopamine is available in the body. Okay, but when you give this beta-2 agonist in combination with the monoamine oxidase inhibitors, there's a lot of norepinephrine level increased in the body, right? So this is actually going to cause a dangerous increase in the blood pressure. Remember, beta-2 agonist receptors can also, stimulate the beta-1 receptors in the heart. So along with this monoamine oxidase inhibitor, they can cause kind of an additive effect. They cause together increase the blood pressure, and that causes the hypertensive crisis. So it's very dangerous, and patient can have stroke and other life-threatening conditions. So you got to be very careful when you give both of these drugs together.